Hi, good afternoon. Thank you for coming to our workshop titled Reducing Black Maternal and Infant Mortality in Faith-Based FQHC. We have our lovely speakers here today who will introduce themselves. I just want to thank you for coming. Oh, you cannot hear me? No? Oh, higher? Oh, that's really high. Okay. I just want to thank you guys for coming, and we will open up in prayer. I'm a student volunteer, and so is my partner here, Jordan. I'm Joanne Lee, and she will pray for us. Thank you.
Hi, everybody. My name is Sarah Love. This is a little bit of our information. I am a family medicine OB. I graduated from residency back in 2019, and I have a really fun job. I am the women's health director and a primary care physician at Crossroad Health Center. That's the local CCHF clinic here in Cincinnati. And then I'm also on residency faculty. I'm specifically on maternity care faculty at the UC Christ Family Medicine residency. So I work here with Linda here at Crossroad, and Dr. West is one of the family medicine residents I work with at Christ. Here's some other information about me: follower of Jesus, doctor, wife, dog mom, and then I'm a foster mom also. We don't have any kiddos with us right now. And then my big desire is to provide equitable, patient-centered, compassionate health care to the most vulnerable in the name of Jesus. So I'll have my other co-presenters introduce themselves.
Hi, everyone. My name is Wendy West. Originally from Kingston, Jamaica, but I grew up in Western Massachusetts, completed my undergraduate career at Wellesley College, my medical education at Ohio University up on the Cleveland campus. I have a really big interest in prenatal care as well as Black infant and maternal mortality and morbidity. I'm Catholic. I'm interested in, again, all things reproductive health and reproductive justice. I love indoor cycling. I'm part of the cult known as Peloton. Love reading historical fiction as well as cooking. And just really happy to be here to talk with you all about such an important topic and all that Crossroad is doing. Thank you.
Hi, everybody. Can you hear me? Okay. My name is Linda Mack. Some of you know me, most of you don't. I'm the women's health nurse at Crossroad Health Center. I have been in this position for a little bit over 3 years, but I've worked in OB-GYN for the underserved community basically all my life, ever since I've been working. So that's been many, many years. So it's obviously something I'm very passionate about. I care a lot about these young moms, and as all of us do, we're all pretty dedicated on this OB team at Crossroad, and that's something I'm very proud of. So having said that, I'm a lifelong Cincinnatian. I am the youngest of 3. I have 2 older sisters. I'm married and have 3 children, and I'm a grandma, and I'm a dog mom, and I just got a Woodstock poster, and I put it up in my office at Crossroad. If that tells you anything, peace. So also I love to read, mostly historical fiction, but I'll read it pretty much anything. And I love to garden. I have a perennial garden at home, so I'm itching to get my hands in the dirt right now.
Okay, thank you guys all for coming to this session. Obviously, it's something that's very important to the 3 of us, and I'm assuming important to the rest of you since you're here. Some of you may have visited Crossroad yesterday on the tour or on previous times here at CCHF, but this is just a little bit about us. We're a Christian FQHC that was born in 1992, born from a conviction that God has a special concern for the poor. Specifically to the prenatal program, so we have 5 health centers, including 2 school-based health centers, and we do prenatal care at 3 of those centers. It was back in 2017, before I was here at Crossroad, we started a prenatal program when we realized that there was a need for high-quality prenatal care in parts of the city where there wasn't much access, especially for patients without health insurance and Medicaid. Dr. West is going to kind of go through some of the statistics and the information about Black maternal and infant mortality and some of the factors that contribute to it across the United States and specifically here in Hamilton County.
So the Numbers for the Black maternal mortality, most up to date for Ohio Department of Public Health, is from 2019. So the information for Black infant mortality is a little bit more recent in 2021. So just wanted to address that time difference. So when we're talking about maternal mortality definition-wise, so death of a woman during pregnancy, at delivery, or within a year of delivery from a pregnancy-related cause. And so that is the number of deaths per 100,000 live births. The maternal mortality rate in the United States, for comparison, is in 2019 was 20 per 100,000 live births. In Ohio, if we're taking into account all birthing women in the state in 2019, that rate was 10.8. If we're just selecting for Black, so women who are identifying as Black of African descent, that rate increases substantially to 59.7 per 100,000 live births. So you can see a little bit of that drastic difference when we're thinking at the country level, state, and then when it comes to individual demographic of Black women in Ohio. So causes of pregnancy-related deaths, when we're thinking about what's the majority of cases, we're mainly addressing cardiovascular, coronary. When we're talking about other, it's more so whether it's preeclampsia or any type of complication related to the delivery, but a lot of times it is related to cardiovascular, coronary, hemorrhage, again, the preeclampsia, and then very rarely we're seeing the amniotic fluid embolism or mental health conditions. A lot of the timing of these pregnancy-related deaths are within the first 42 days, and outside of that, it is during pregnancy, so prior to the delivery, and then kind of within that 43-day to 365 days is about 19%. When we're discussing Black infant mortality, that is the death of a live-born infant prior to their first birthday. That's the number of deaths per 1,000 live births. In the United States, for example, that number in 2021 was 5.4 per 1,000 live births. In Ohio, in 2021, that was 7.0. If we're separating out between Black infants and white infants, that number changes from 14.2 for Black infants and 5.4 for white infants, just to kind of give a comparison. Interestingly enough, the county also had data specific for Hamilton County between 2018 and 2022. That's an average of about 8.1 infant deaths per 1,000 live births. And if we're breaking down between Black infants and white infants, that's 13.3 to 14.3. So kind of seeing that disparity and being able to look at the numbers from the country level to state to specifically Hamilton County. When we're looking at infant mortality rate in Hamilton County and kind of what are some of the numbers that have, what have the numbers looked like throughout, if we're looking kind of in these segments of time, it has increased a bit. Between 2008 and 2012, that number was 10.2 per 1,000 live births, and then it's starting to decrease a bit to currently being at 8.1 per 1,000 live births. But if you look back here, that number for Black infant mortality has stayed pretty high and has been sometimes double or triple that of white infant mortality. And then if we're looking at infants identifying as Latino descent, that number is less than Black infants and more than white infants. Looking at leading causes of infant death, really the most significant is preterm birth-related causes. So that's low birth weight causing complications, NICU stays, and for those infants ultimately resulting in their passing. Next is sleep-related causes, and we'll talk a lot about safe sleep. That accounts for about 21%, and then 19% being birth-related defects. Within Hamilton County, one of which is Cradle Cincinnati. So looking back and seeing that 21% of infant Black infant mortality is related to sleep. Cradle Cincinnati is specifically committed to helping every baby reach their first birthday. They have this collective impact model, kind of looking at support systems for Black birthing people and how to reduce the mortality rate of infants as a result. Engaging with regional hospitals, they're engaging with healthcare professionals, FQHCs, with academic institutions including Christ Hospital, UC, Tri-Health, Mercy, and social services. So looking at different whether it's WIC programs, what can we get moms signed up for, giving out car seats, helping women find cribs and places for babies to sleep, talking about the impact of co-sleeping, things that are really important to address that 21%. And then also strengthening mental health services for birthing people. That's a huge part of it as well in the prenatal and postpartum stages. Another amazing organization is Queens Village. They're actually nationwide. The branch in Hamilton County is focusing on, again, maternal equity and centering voices of Black women, addressing some of the racial disparities that affect maternal and infant mortality, and the different systems, whether healthcare systems in place, when we're talking about implicit and explicit bias, when we're talking about lack of regard for women's pain or symptoms they're experiencing, and also just kind of challenging the belief systems around birthing experiences for Black women and believing Black women when they're talking about their pain. All of these things are kind of woven into contributing to that disparity in the Black maternal mortality and Black infant mortality rate. And I think recognizing that can be very uncomfortable, but also very empowering, because there are things that we can do to address it at the individual and the systemic level. And then also helping to empower these women, allowing them to feel empowered to talk about their experiences, engaging with their providers, and making sure their providers are giving their patients that space to do so. And then social equity work, again, centered around the implicit bias piece. And then also just talking about these uncomfortable birthing experiences, because it's going to help to prevent this in the future, we believe. I'm going to hand it over to Dr. Love to talk about the Crossroad demographics.
Awesome. Thank you, Dr. West. Okay. I'm going to go through some of the information about Crossroads. This is based upon 2023. I see Vivian here, who helped me gather a lot of this data. In general, we have a pretty young patient population. If you just see here, I kind of wanted to lay out like who are our patients at Crossroad, who are we taking care of, and who comes to us. If you see here, about 14% of our patients are teenagers and 45% are 24 and under. So in general, we have a pretty young patient population. And even recently, I feel like we've had a lot of patients under the age of 15 coming in pregnant. If you see here, our largest demographic across all three of our health centers is our Black/African American. And the next one is Hispanic Latino, and then, white, and then Hispanic Latino. And then we have other people who have declined or marked themselves as other race. If you see here, insurance status, like most FQHCs, most of our patients have Medicaid. The rest are self-pay, and then if we have a handful of patients with private insurance. Just based upon how we bill for prenatal care at Crossroad, most of those patients that have commercial insurance end up getting transferred to our partner hospitals for their prenatal care, because it ends up being kind of too expensive I don't need to get into that. It ends up being more expensive for them to stay at Crossroad because we don't do global billing. So they have the private insurance here, but most of those patients end up transferring out. So I'd say 90-95% of the patients are self-pay or are on Medicaid that we take care of throughout the course of their pregnancy. So obviously we are at CCHF. It's a Christian conference. We at Crossroad Health Center care deeply about providing good health care and medical care to our patients, but we also care about what does Jesus have to say about this? And these are just some of the scriptures that I have found why this work matters to Jesus and why it should matter to us as believers in healthcare. You guys can just take a look at this here. But in general, I think God calls us to seek justice, and part of that is taking care of the underserved and those who have been marginalized traditionally. And especially with all the statistics that Dr. West presented to us, I really feel like specifically at Crossroad, we're called to specifically care for our Black moms and babies to reduce this really horrible difference in the maternal and infant mortality rate that we see, not just in Hamilton County, but across the country. And I think that's Jesus' heart too. So those of you at FQHCs are probably familiar with UDS measures. So the things that, basically it's the things that us as FQHCs are tracked on, measures that we tried to improve on in order to improve health outcomes. So those for prenatal care is early entry into prenatal care. Linda and I always talk, if we can get people into prenatal care and we can get them to come consistently, usually we have decent outcomes. The most nervous I get is when we can't get a hold of patients, so they're coming in their third trimester. And that's anecdotal experience. But that is one of the goals, is to get patients in before they turn 13 weeks. And then if you see here, this is actually something that I'm actually pretty proud of. I'm going to kind of go through these statistics, and we'll go through some of the initiatives that we've been doing over the past few years to kind of improve these outcomes. If you see here, we've been kind of increasing our early entry into prenatal care. So if you see in 2021, 2020 was decent at 76%, 73%, 75%, and almost up to 78% in 2023. And then if you see here, this is broken down by racial demographics. And one thing that I am proud of is that for our patients that identify as being Black, we have 87% of them in their first trimester. So the ones that we have kind of the worst kind of statistics for are our Hispanic or Latino patients. We do not turn anybody away based upon how far along they are in pregnancy. So I think the main reason for this is we have patients immigrating here and oftentimes showing up at 28 weeks, 36 weeks of pregnancy. So it obviously affects our statistics, but we won't turn anybody away based upon like their gestational age at presentation. The other thing that we're tracked on is our low birth weights. As Dr. West was saying, the leading cause of infant death is preterm birth. So one of those things is low birth weight and then also our preterm birth rates. So that's something that we work really hard to implement measures that are going to reduce both of those things. And if you see here, things have improved greatly. We're down to 8.43%, and our quality metric that we are trying to get to is at 11%. So, and then if you see here, there's only, I don't have the exact numbers here, but there's very few that are in this like less than 1,500 grams. Most of them are in this 1,500 to 2,499 grams, so, of our low birth weight infants. And most of the time, low birth weight is associated with prematurity, but not always. Sometimes you have a full-term baby that was diagnosed with growth restriction and ends up being born small, so they're not always hand in hand. And then the thing that I'm not quite as proud of is our preterm birth rates. Overall, it's at 9.41%. And our highest preterm birth rate is in our African American patient population at 14.3%. So we definitely have some work to do with that, but we're going to go through the things that we're doing to try to reduce that. So how do we do prenatal care here at Crossroad? It takes a team, kind of like it takes a village to take care of children. It takes a whole multidisciplinary team to take care of our pregnant patients and their families. So I'm a family medicine trained physician. There are several other family doctors at Crossroad. And we also have a handful of OBGYNs from University of Cincinnati that come out to all three of our sites, depending on which site it is, anywhere from like one time a week to, once every 2 weeks. So that we really appreciate that relationship with the University of Cincinnati, because as a family doctor, I don't love taking care of high-risk patients that are showing up at 36 weeks, but I'm happy to do their initial intake and have their next appointment be with the OBGYN that is connected with the high-risk OB center in town. We have Linda is our dedicated women's health nurse. All of our nurses have some training in prenatal care and are able to do prenatal intakes if needed and answer questions, but we do try to get most of those questions answered by Linda, and she does all of our prenatal health intakes. We have behavioral health consultants, care coordinators, a pharmacist, medical assistants, and front desk staff, and I know I'm missing people here, but everybody's involved in taking care of our pregnant patients. And then as far as how prenatal care goes, a bulk of it is performed by family medicine physicians. Most of our family doctors do not do deliveries. They work at Crossroad and do prenatal care. I'm the only one that kind of has a dual appointment that does deliveries over at Christ Hospital, where Dr. West is at. And then we also have 3 OBGYNs from University of Cincinnati, and they deliver at University of Cincinnati, one of the other local hospitals in town. Our patients have 2 options of delivery, so they can get their prenatal care at Crossroad if they go to University of Cincinnati. They're taken care of by OBGYNs and OBGYN residents, and then we try to get the OB-GYNs from UC to see patients, at least for some of their visits. So hopefully there's a familiar face there that when the patients are going to be going in for their delivery. The other option is Christ Hospital, which is where myself and Dr. West are at. In the faculty group there's 3 family doctors, including myself, and 2 certified nurse midwives, and we work with the family medicine residents. For these patients, they transfer out of Crossroad at 32 weeks of pregnancy to the Family Medicine Center at Christ. The reason for that is, in general, we try to take lower risk patient population. As family medicine trained physicians and midwives, we really want to get to know our patients. So it's important for our patients to meet the other doctors and midwives that may be involved in their care at the time of delivery. And then Linda is the one that kind of helps out the most with this, but coordinating transfer of care for higher risk patients. So even though we have OBGYNs at our office, they're not there all the time. We have kind of criteria in which we transfer people out, and Linda is the one that does that for us. So for example, we are not taking care of people that are actively using fentanyl or have active HIV or a handful of other conditions. But in general, we take care of a relatively high risk patient population for primarily family medicine-based FQHC. And then for our postpartum visits, Linda is going to be talking about this in a little bit. We've restructured that in the past year, but we are doing like a 1-week postpartum visit phone call that Linda does, and then an in-person visit at 3 to 6 weeks postpartum, and then we have individualized timeline of care after that. The first thing that I'm going to talk about, one of the initiatives that we started back in, our first group was in 2021.
Yeah.
Dr. Christine Ferguson was the women's health director before I came on, and she had gotten a grant back in 2020 before the pandemic hit, and that kind of delayed things. But the purpose of it is that there's good evidence behind group prenatal care that it reduces preterm birth rates, especially among Black women. And as we were talking about before, preterm birth is the leading cause of infant mortality, especially among Black infants. It increases breastfeeding rates, reduces low birth weight rates, and overall improves patient and provider satisfaction and care. As a doctor that has participated in group for, I guess, almost 3 years now, it's a really fun thing to be a part of. I think it has improved my job satisfaction, and I feel like I get to know those patients a lot better. And I feel like there's just more space and room for education and for people to have more autonomy and control and empowerment in their pregnancy and birthing experience. It was initially funded by a grant through the Ohio Department of Health through Cradle Cincinnati, which Dr. West talked about in 2020. And the primary goal of this grant at that time was to reduce preterm birth rates in Hamilton County. And then, our first group prenatal cohort was in April of 2021, so almost 3 years ago. And then I'm going to have Linda talk about a little bit about our group and kind of what that looks like.
Yeah, let's see. We started, well, we were still in COVID. We were just coming out of COVID, I guess, when we started our group prenatal program. And it has gone very, very well. We usually have anywhere between 3 to 5 to 6 moms in our groups. Oh, I'm sorry. Okay, is that better? Okay, all right. We usually have about 3, maybe 4, 5 moms in our groups. And the hard part of getting patients in is the recruitment part. And I'm usually the one that does that, or Dr. Love, or one of the family medicine doctors who sees that particular patient for their prenatal intake. And a lot of patients maybe they have a job. Now, our prenatal program, a group program, is held on a Wednesday from 1 to 3. So that's a 2-hour, time commitment. So if they have kids, if they have jobs, if they have other things going on in their lives, it's difficult for them to do that. But they're thankfully the ones who want to do it really want to do it, and we're thankful for that. So getting them into group is a process, and then once we start group, the first group can be a little awkward because everybody's new, everybody doesn't know everybody, everybody's kind of strangers. But we try really hard in that very first group to let these patients know that this is your group. This is not our group. This is your group. This group belongs to you. What would you like to get out of this group? And we put it on a flipboard. What's important to you? Obviously, support. Confidentiality, extremely important. So we go through all of that. Nothing will be said here. It's just like Las Vegas. Whatever happens in this room stays here. And, we have to pinky swear to that. So, nothing is off limits. They can talk about whatever they want to talk about. We can get into long discussions about important topics, even if it makes us stray off our timeline a little bit. That's okay. If we're talking about something important, then that's important for them. We also let them know that they are important to us, and that maybe they think, well, if I'm in group, I'm not sure if I'm going to be getting the kind of care I would if I was just going in to see the doctor and then have that one-on-one conversation. So kind of unique to our group process is that our patients come in to see me first. They come into the group room. They actually do their own blood pressures. They get their own weights. So they are taught how to do all that. They record all that. Then they go back to see the provider one at a time. So everybody gets their own individualized care. And that's a little bit different than other models. But I think it works better for us. And then everybody congregates back into our classroom. Dr. Love is in there, or Dr. Ng if she's a provider that week. And we have groups. So we have group speakers who come in. We've got a lot of good people in the community that will come in and talk to us and to our group. And these girls just get a lot of information, and I think they have a sense of ownership and belonging when it comes to group. They even become friends. I had a girl last week that said, is so-and-so going to be a group? I was like, yeah, she's going to be a group. She said, oh, good, because I've got a big bag of baby clothes for her. I said, okay, good. So, those kinds of things go on, and they kind of form friendships, and that's good because some of those girls don't have a lot of friends. They don't have a lot of support. Maybe those girls in group are the only support that they have. So those things are all important. And we just try to do the best that we can to give them the best care that we can and keep working on getting these numbers up, and I think we're headed in the right direction. So that's it for that.
Okay. Did you want to talk about some of the?
Oh, yeah. Well, I was talking about our partners that we use. Some of them come in and talk to our groups. This one, well, actually, we're having group this coming Wednesday, and I just call them the boobs group. And the boobs group, they're wonderful. It stands for Breastfeeding Outreach for Our Beautiful Sisters. Well, they're going to come in and talk to group, on Wednesday, and they're awesome. They bring like puppets, and they take up the whole time. I mean, they really are into this breastfeeding thing, and they really get those moms excited about breastfeeding. So I'm looking forward to that on Wednesday. And then we have March of Dimes, who's always a backup for us for support for our groups. They're always happy to help us with any questions. Beach Acres, they are, how would you describe?
So Beach Acres is kind of, I'm actually a foster parent through Beach Acres. They have a whole foster section of it. The part that we work through is the Beach Acres Parenting Center, and they provide support for parents to make them feel more empowered and cared for and educated. So what they typically do when they come to Crossroad is they talk about adverse childhood experiences and resiliency. And what to do. A lot of our moms have experienced trauma before in their lives, and it's kind of, this is a new fresh slate that you are the protector of your child, and these are the things that you can do to write a different narrative for your family and for your child to prevent them from experiencing any trauma that you may have experienced in your life. So.
Yeah, and I think it's something that they hadn't thought about before, and everybody's had adverse experiences in their lives, whether it's a death or trauma of some kind. Sometimes it's violence, sometimes it's domestic abuse. Sometimes people, unfortunately, don't get raised up, they get jerked up. So it's a really good talk, and they do a lot of good. And they also will see our patients for us. They offer counseling services, so that's a good thing. We already talked about Cradle, Cincinnati. We already talked about Queens Village. Dr. Love is going to talk about our doula program. Also, Dr. Love introduced us to another group called Young Life?
Young Lives.
Yeah, and Young Lives is a group of Christian women. Is it all? I guess it is.
So. Yeah, I think
Yeah.
it's all women.
And they mentor young pregnant teen moms, or moms in general, I guess.
Yeah. Up until the age of 21.
Oh, okay.
Yeah.
So that's a really good resource for us as well. We work a lot with the Free Store Food Bank, which is here in Cincinnati. We have food pantries at all three of our sites. We do screen for food insecurity for all of our patients. So if they are in need of food that day when they're there to see us, they're actually able to take food home with them that day.
Sweet Cheeks.
Yep, Sweet Cheeks. Sweet Cheeks is a diaper program. They are actually a diaper bank. And those who belong to Sweet Cheeks, when I say belong, I mean who are signed up into their program, are eligible to get 50 free diapers per month per child until that child is 3 years old. So that's a great resource. We are able to give them those at our OTR location and at our Harrison location. Not at our West location yet. I believe we're still on a waiting list for that. So, but those patients can still go to OTR or Harrison to get diapers. So that's a big savings because, as you know, diapers are very, very expensive, and that's a lot of money when you don't have a lot of money.
Thank you.
You're welcome.
Awesome. So I just wanted to give a few quotes. I called some of our patients up that have done group that you guys can see up here. This is Camilla. She did one of our first groups. She said, I learned a lot of helpful things, such as more about breastfeeding and getting prepared for delivery. I was the only one in the group who was not a first-time mom. I like being able to help other moms feel comfortable in pregnancy and leading up to their birth. This was my first time having a boy, so I learned more about his circumcision. And then Nay is a patient who is currently in group, currently pregnant, and then also she's working with our doula program, which we'll be talking about in a little bit. She said the other day, it has been really helpful. I learned about different birthing techniques and methods for pain control that I did not know about before. I'm excited about that. I'm able to ask questions in group, which is helpful for first-time moms. So. The next program I'm going to talk about is our doula program. Some of the evidence behind doulas, I'm not going to spend a ton of time with this, but basically doulas are helpful at reducing cesarean section rates and preterm birth rates. If you see here, reduce cesarean section rates 20.4% versus 34.2%, and then at 22% lower odds of preterm birth rate for women with doula care. Also increased rate of breastfeeding initiation, and then a non-significant 12% absolute reduction in cesarean birth, and increase in exclusive breastfeeding during delivery hospitalization among Black non-Hispanic participants. There was also, thank you, Brooke. A doula is how I describe it to my patients. It's kind of like a supportive birth worker, birth partner that is trained to provide some prenatal education and support in pregnancy and in labor and delivery. So most of their evidence, I think, is behind, like, during the actual delivery. They are there to support patients. I always tell patients it's helpful to have a doula, even if you have a partner or a parent there. Their job should be to be your mom or your husband rather than somebody who is going to be helping with pain control and helping you, like, make those decisions about your birth experience. So it's nice to just kind of have a trained person. They'll help with pain control, patient movement, a variety of different things. So,
Paid for by insurance?
right now, no. It's about, I'd say, anywhere from, like, the group that we work with, if patients were to have to pay for it out of pocket, it's $1,200, which is a big chunk of money for people who don't have a ton of income. Then if you guys just see here, this is, but it's anywhere from, like, probably $1,000 up to $2,000 depending on who you're working with. Here's some more benefits of it, and also reduce stress and anxiety. There was this study that I found. There was this Yaya V. Kagindi doula project, and this was not specifically to Black women, but to Native and Hispanic families in New Mexico. And they had over 8 years of data collection, so that's why I thought this was interesting to look at. It's not just over a short period of time, but they had excellent rates for preterm birth, low birth weights, C-section rates, and then postpartum depression. And I really feel like in our experience working with our doulas, that Black doulas are uniquely suited to help combat racism and implicit bias in their Black clients that they experience in healthcare and advocate for them in tangible ways. So I'll be talking about our doula program next. So how do we get funding for this? It's the same grant that Dr. Ferguson had applied for back in 2020 that provided funding for our group prenatal care program. This specific grant cycle was specifically targeted at reducing Black infant and maternal mortality and improving health equity for our Black patients. So what we applied for was to provide doula funding for 30 patients over the course of 2 years. I initially applied for it for our highest risk patients. We're at the point now where we got a little bit of a late start with it due to some credentialing stuff and some delays. So it's basically any of our Black patients are eligible if they're interested. And the group we work with is called Me and She Doulas. It's founded by a lady named Sashida Tafari, and it's an organization run by Black women for Black women during pregnancy, childbirth, postpartum, and parenting. And this is kind of, I found this on their website, is kind of their mission statement. And I think it's helpful, especially with some of the things that Dr. West was talking about, to have, an educated Black woman helping a birthing Black patient make decisions about her care. And I do think that it's a relatively collaborative relationship. I think that I have a good relationship with Sashida where we're able to have conversations about things. But our patients that work with her just seem to be a lot more educated and a lot more confident in going into having a baby. It's an ongoing program. I do not have really any statistics or data to give you about it because we're still in the middle of it right now. But I wanted to give you a little bit more information. We have patients can either choose from the prenatal birth program, so they work with Sashida and her group during pregnancy, and then the doula comes in when they are in labor and having the baby in the hospital. The other option is for postpartum support, and they help with breastfeeding, mental health support, providing an extra hand with meals, grocery shopping, childcare, and all of the above. And then also are trained to help, identify warning signs of, like, say, preeclampsia or postpartum depression. Here's a few quotes. Brianna, she made me feel comfortable. She felt more like a family member than a doula. She taught me a lot of things about contractions and pushing. She helped go through my options with me. I initially wanted to go natural, but decided to get an epidural, and she did not make me feel bad about it. She also provided me with a tea to help increase my low iron. I recommend other women work with a doula. Brianna, I think, was our first patient that worked with this doula program. And then Shemaya is currently pregnant. And she told me the other day, I felt a lot less anxious since working with Soshita during my pregnancy and preparing for the birth. Then I do not have a quote from Latasha, but she told me in one of her postpartum appointments that she was thrilled to be working with the doula. She is a single mom of 4 children, including a newborn. And the doula went grocery shopping for her and prepared her some meals. She also watched the baby and her other kids while she took a nap. So yes, it's really wonderful, and she was just thrilled to be working with her. With the postpartum program, it's 20 hours of in-person care and contact that is allotted. And then Markeia is one of our patients that's in both group and in doula care. And the other day she told me, the most helpful part of the support group is being around females who understand what I am going through. I get to ask questions and learn about things that I did not know. The best thing about being a group is that I never feel alone. And then for the doula care, she has helped me think about things I would never even think about in labor. She is very nice, and it'll be great to have her in the room when I am in labor. She will keep me calm. So, and then Markeia is a teenager also, so I think even more of a reason is that relatively high-risk patient population. And she also has had some comorbidities in pregnancy, so I'm thankful for the care that she's getting. As far as the last thing is kind of our postpartum restructuring. The reason that we did this, ACOG and the Society of Maternal Fetal Medicine basically put out some information in the past couple of years about how we need to improve our postpartum care. The standard is people who have C-sections, come in for your incision check at 1 to 2 weeks postpartum, come in at 4 to 6 weeks for your postpartum visit, and then, hey, follow up with us in a year for your annual. And I think as Crossroad, as a family medicine-based FQHC, we have that unique setup where oftentimes we are still providing primary care to these patients and we're taking care of their children. So I think we do have more points of contact than the average OB-GYN does, just because we're seeing people for more than just their obstetrical care and postpartum care. But both ACOG and SMFM have recommended having more of a postpartum continuum and making care based upon patient-centered care. What does the actual patient need, not just should we have everybody just come in for this 4 to 6 week visit. So in order to kind of what we did at Crossroad is that we have a RN check-in at 1 to 3 weeks. Typically, Linda calls these patients by phone, and we have a template put together that basically asks them screening questions, including how the patient's doing, if they're breastfeeding. She does an Edinburgh postpartum depression scale on them, screens them for preeclampsia symptoms, and then goes through a variety of different questions with them. And then we have a protocol in place that basically she schedules people for earlier in-person appointments for a variety of reasons, which she will talk about. And then we have a standard postpartum visit at 4 to 6 weeks. And then some of the things that we made, some of the things that Dr. West was talking about, what are our causes for maternal mortality? About 50-ish% of maternal deaths are in the postpartum period. So we have so many points of contact with patients when they're pregnant, or we hope to, and then maybe one or no appointments in that first year postpartum if they don't come to their postpartum visit. So there's just a very stark contrast in the amount of visits that patients get and the amount of point of contacts that people get when they're pregnant versus when, after they've delivered. There's a CDC report that came out in 2022, I think, 2022. And basically, specifically for Black patients, cardiac causes and preeclampsia are the leading causes of maternal death. And then in white patients, mental health, either postpartum depression, patients dying by suicide, or overdoses. So those are the two things that main two things that we've targeted in improving postpartum care and reducing our maternal mortality rates. And again, obviously there's overlap in that white patients can get preeclampsia and plenty of our Black patients deal with postpartum depression. So we are screening everybody for both of those things. And then another goal that we have is to increase our compliance with postpartum visits, and for patients that want contraception, we want them to be able to get the contraception that they want. So if you see here, Justin, our clinical informaticist, helped me pull this information. We did a PDSA cycle starting last July, basically trying to increase our postpartum visit rates and using this 1-week check-in that Linda's been doing to increase that. So if you see here, I'm not going to go through all these numbers, but green is good, red is bad. And as you can see, once we did the PDSA cycle, we have a higher percentage of patients coming in that 12-week period. And one of the things that Justin had told me, even in this yellow and red, I guess, is that there were some patients in this yellow category that were like still within their 12-week window and had appointments coming up. So the numbers are actually probably a little bit better. I'm going to have Linda talk about our postpartum hypertension screening and kind of the things that we're doing to identify postpartum preeclampsia.
We are screening patients for pregnancy-induced hypertension because obviously it can be a big problem. So anybody who's had high blood pressure after their delivery or during their labor delivery, needs a blood pressure check 3 days postpartum. So that needs to be scheduled. And does the hospital schedule that for them or no?
No. Usually we tell patients to get scheduled for that. If it's severe preeclampsia, 3 days postpartum. If it's mild, like gestational hypertension or preeclampsia, at 7 to 10 days. Usually we're telling the patients to call and schedule that appointment, and then Linda, like our care coordinators, are seeing the discharge summaries and they're getting the patient scheduled. And then Linda's also doing the 1-week check-in and getting them scheduled. So there's kind of several points of contact in which we're doing that, getting them scheduled. So we try not to miss anybody.
Yeah, I am usually notified by either Christ or UC of deliveries. So I have a list of people who have delivered, and I know who I need to call to do those follow-ups. Generally, I try to get a hold of them, ideally with them that first week postpartum, that first week that they're home with their newborns. And they are asked a group of questions, as Dr. Love just talked about. And one of those is, are you having any headaches, blurry vision, any swelling, shortness of breath, blood pressure, you feel like your blood pressure is elevated, any chest pain, those types of questions. And during that screening, I also do the Edinburgh postpartum depression screen. And that's very, well, I would say necessary, because it allows for early intervention. And we have come across people who are, depressed, and they don't even know it. Like, if it wouldn't have been for a phone call that they got and went through the postpartum depression screen, they might never have gotten the help that they needed. Case in point, I called somebody, she was 3 or 4 days postpartum, to do this depression screen and to do this postpartum screening. And so she scored very high on her Edinburgh. She scored at about a 13, I think. And that included suicidal ideations. So I called and got her in the very next day to be seen by one of our providers, and come to find out she was actually thinking about jumping out her 6th floor apartment window. So that's something that, we can see right away that was a very necessary call, and that we caught something, which is a very good thing. Mm-hmm. So we're thankful for that. Mm-hmm. So besides the Edinburgh.
Blood pressures that you have done within 3 days, is that at home?
I'm sorry?
Is that at home, the blood pressure screening at day 3?
Are they sent home with a blood pressure cuff?
So we give patients, we'll send in prescriptions for blood pressure cuffs, or for our uninsured patients, we have free cuffs through a grant that one of our population health manager got for us through the American Heart Association. We give out free cuffs. So patients are doing that at home, but we do the 3-day blood pressure check in clinic. Yeah. So if there isn't an OB provider at the moment, the first line is to be seen by a doctor that does prenatal care, so one of our family doctors or one of our OBGYNs. If that's not possible, then it's scheduled with a nurse visit with Linda or one of our other nurses, and there's a protocol in place that of the questions that they're supposed to ask and everything that's supposed to be done, including like calling me or calling one of the OB-GYNs that's on call to kind of come up with a plan. So, and then I'd say, yeah, for the postpartum depression screen, basically if their Edinburgh is 10 or higher, or if Linda has concerns, she has to schedule them, I mean, within a week, but obviously the patient that was suicidal, she got within a day with one of the doctors that does prenatal care, or with one of our behavioral health consultants. Just quickly here with our Edinburghs, if you see here, after we did this PDSA cycle, we have greatly increased rates of getting a postpartum depression screen done within the first 12 weeks. And I don't have this like differentiated out by when it happened in the first 12 weeks, but I really think most of these are happening at least once within the first week because Linda's doing these screens. The last things I wanted to just mention, just because it's not that exciting, but it's been really helpful for me. This is something myself and Justin, our clinical informaticist, made a couple years ago. There isn't a great way to track our pregnant patients and what's going on with them in our EMR. So this is a spreadsheet that we created. If you see here, what's blocked off is the MRN numbers, but it basically has who the PCP is, where they're delivering, their gestational age, and that updates based upon the calculation he put in. I'm not an Excel person, he is. He did that for me. And then it pulls, once a week he pulls in like most recent appointment, next scheduled appointment if they've had a canceled appointment. And then Linda's going through this every Thursday, and she's identifying people who have missed appointments and gets them scheduled. So we've seen great improvement in like how often we're seeing patients. And I think one of my greatest fears as a doctor that works in this setting is that like somebody just stops coming to their prenatal appointments. We don't know about them. We don't realize that we're not seeing them, and then like there's a bad outcome. And we did have some near misses before we implemented this, and we can't make people come to their appointments, but we can try, and we are at least aware when people aren't coming, and we can, Linda is like a sleuth, and she tracks people down. And then sometimes we lose people to follow up or they move, but at least we know that they're not here. So, and then I'm gonna go through this. And then also we have monthly prenatal meetings that I lead with all the prenatal providers, and we go through new evidence-based updates in obstetrics and prenatal care and different initiatives that we're doing at Crossroads.